So where we're moving and tying it back to disease severity, I like to talk a little bit about this risk stratification or risk assessment. So typically how we behaved as physicians and patients historically is very reactive. We had this kind of reactive behavior, is that we waited for patients to complicate and progress with either strictures or fistulas and say, wow, you've got severe disease, you now have a complication. And we would then say, well, maybe I need to treat you differently. But to be honest, developing complications is the end game. We don't have drugs that reverse scar tissue, for example, so that usually leads, to surgery. Sometimes the fistulas could be managed with medications and antibiotics, but recurrent fistulas, for example, means that the patient needs to be operated on. So what we figured out is that we were defining risk at the end. So what we started figuring out is that, are there ways that we can actually risk stratify a patient at diagnosis? Are there tools or kind of hints, crystal ball in a sense, of a patient who presents uncomplicated and say, well, you have certain characteristics, therefore I'm going to treat you differently. And so really what this comes down to is trying to figure out what are the best risk factors. So there are some tools that are being developed and some that have already been out there that actually say that if you have, for example, female gender, a 16-year-old, so age-wise, you've got small bowel and perianal disease, and you're positive for X number of markers we could measure in the blood, that we could actually, in a visual display tool in real time, put in all these variables, kind of toggle them in, and it shows a visual of what the trajectory of the prognosis is. So this tool is called Prospect. So this tool has been developed in both pediatrics and in adults. And we're currently looking to see how does that impact patient and physician decision-making, meaning will I make a change if I have something at diagnosis that actually will predict how a patient will behave. What that means is if you're at high risk of developing a stricture or a fistula, we need to intervene early. We're not waiting for you to complicate and then pull out the best therapy we have. So this whole proactive approach and risk stratification, I think, is a game-changing and transformative moment for Crohn's disease. And so we're really pushing to make this part of the narrative and see whether or not patients are also interested in knowing how I'm going to be in 3 years. It's hard because you just want to get through the day. So that, discrepancy between or disparity between what the patient wants to kind of do today and just get through today, and here we are saying, well, we want to prevent you in 3 years from now from developing a complication that needs surgery. It's hard to reconcile 3 years when I'm in pain or I just want to get to work. So these are the things that we need to start really studying and figuring out how we can get patients and physicians to define risk the same way.
The reason that we're now doing risk assessment in patients with Crohn's disease is that we've realized that the symptoms don't really reflect the underlying biologic inflammatory activity. So we need to look beyond symptoms to predict how patients' disease course will progress. We also know that Crohn's disease almost inevitably progresses from an inflammatory aspect of the intestine to involve transmural complications, such as strictures that can lead to blockages and fistula that are abnormal connections between the bowel and another organ or even the skin. What we are trying to identify in patients are those who are at greatest risk for a more rapid progression to the complications of strictures and fistula that result in hospitalizations and surgery. And we've learned that factors beyond symptoms are important regarding that prognosis. These factors include age at diagnosis, how much of the gut is affected, whether or not there are actually complications at the time of diagnosis, such as the presence of perianal fistula. Patients who smoke cigarettes have a bad prognosis. And then finally, we've recognized that patients with deep ulcerations are more likely to progress to stricturing or fistula. And these are the individuals that we want to focus our most aggressive therapy to prevent that progression and the need for hospitalizations and eventual surgeries. We are hopeful that early identification of high risk will impact on long-term outcomes. However, this is actually a hypothesis at the present time. We know that our conventional step-up approach to these individuals does not really affect the long-term outcomes. So we are anticipating with our new, more effective therapies that often include biologics that we can impact and actually halt the progression of the disease.
So I think it's important to understand that once you do complicate, there's significant morbidity. And again, it gets back to the discussion on how long do you want to wait to define something that you could maybe prevent, and get that idea that how can I prevent a complication? Because once complications occurred, there's surgery, there's hospitalizations, there's weight loss, there's implications, for example, on fertility and pregnancy. That's something also that I deal with, which is a patient comes to me and says, I want to get pregnant. And our conversation is, we need to get you better. We need to minimize morbidity. We need to get you to a point where you're not sick during pregnancy, you have a healthy pregnancy. So all of this idea of let's be proactive to minimize morbidity and the complications that arise with advanced disease means I need to treat you early, before a complication occurs. So it ties back again to the whole discussion on Crohn's is a progressive disease. You need to get on good therapy, and those that will progress, you need to predict who will progress, and you need to intervene at that window of opportunity.